Hello, everyone. Welcome back to Department of Medicine Grand Rounds. I want to say thank you to everyone for an amazing year at Grand Rounds. It's been an honor hosting Grand Rounds this year as we welcome eminent speakers from across the world to share their expertise with our community here. We do have one more Grand Rounds next week, highlighting 3 of our residents in the Mentors of Medicine program. Then after that, we'll take a hiatus for the summer before returning in August to start next academic year's Grand Rounds. Today, it is my pleasure and my privilege to introduce 2 of my colleagues, co-chief residents, and dear friends, Dr. Francis Lowe and Dr. Karl Wallenkampf. Working with them and our 3 other chief residents, Dr. Kelly Gorell, Dr. David Lambert, Dr. James McFarland, this last year has been an absolute honor for me. I could not have asked for a better group of co-chief residents to lead the internal medicine residency. This year has been an incredibly fulfilling and fun experience for me, in large part due to working alongside these 5 amazing people that I get to work with each and every day. The 2 who are speaking today, Dr. Lowe and Dr. Wallenkampf, will each be talking about topics incredibly dear to their hearts that directly impacted how they approach their role as chiefs. I'm incredibly excited for them to share this with the greater medicine audience today. First up, we have Dr. Francis Lowe. Dr. Lowe obtained his undergraduate degree in applied mathematics from Harvard University. He then joined us here at WashU, where he obtained his medical degree, and then, of course, internal medicine residency, as well as chief resident year. He's always had an acumen for medical education, and especially developing clinical reasoning, one that I have seen in full display and honestly kind of benefited from this last year working alongside him. As a second-year medical student, he worked with Dr. Jay Piccirillo to create an elective for first-year medical students titled Mental Models in Medicine, a class aimed at introducing and developing clinical reasoning skills in these students. As chief, he has aggressively pursued expanding educational efforts to help shape the reasoning skills for our residents and medical students. Even from the beginning, before we were officially hired as chiefs, he created a brand new session for interns during their orientation aimed at getting them prepared to learn as effectively and efficiently as possible from day one. Part of me wonders whether his true passion is clinical reasoning or absolute ruthless efficiency in everything he does. I mean, seriously, this man is a machine at identifying inefficiencies and getting them fixed. I think anyone who's worked with him this last year can attest to that. In recognition for his commitment to efficient education, he was voted Teacher of the Year for internal medicine this last year, as well as Teaching Resident of the Year as a senior resident last year. We are extremely fortunate that he will be staying with us after his chief year and joining the Division of Hospital Medicine. Today, he'll be sharing his schema for teaching clinical reasoning. Please help me welcome Dr. Francis Lowe.
Can you hear me okay? Good? All right. So thank you, Edward, very much for your kind introduction, and the honor has been all mine to work with these wonderful group of co-chief residents. We've got our disclosure slides here. The title of my talk today is The Right Map for the Right Territory, Improving Teaching Clinical Reasoning. How many of you have ever felt like this while you're on the wards or in clinic? Maybe it was a consult that didn't really make any sense. Maybe it was a referral for something that was going to self-resolve. Maybe it was a presentation that just really missed the big picture. Or maybe it was an epic chat for a page about pain evaluation, and when you go to see the patient, they're sleeping. Or maybe it's frustration with yourself, having done a workup, but then realizing that the answer was in history all along. We're clinicians, but we're really, on a broader scale, we're problem solvers, as Dr. Atwood once put it. She identifies as a problem solver. And we as learners, we face a lot of problems in medical school. We face a lot of problems in residency. And our task is sifting through the noise in order to find the signal. And that's what I want to talk to you about today. And this is what I want to share with you today is my teaching framework for how to teach clinical reasoning and to help provide learners a map from day one to help them feel a little bit less lost. The right map for the right territory. I call that map RobCart. It's a simple, generalizable, powerful framework for setting up the problem in the right way, or in a way that's amenable to being solved. When you see a low blood pressure, what's your first question? What about a high potassium? What about a consult for bright red blood per rectum. Maybe for case 1 you thought, oh, well, recheck it. Maybe you thought, how do they measure it? Or maybe you thought, are they talking? Or maybe for the potassium you thought, well, we should recheck it. Maybe it's hemolyzed. Or maybe it's for the bright red blood per rectum, I want to see a picture of it. If you notice, all these questions basically fall into the same category. Is it real? And then if you take another look, you realize that this question applies to every concern, every finding that we ever hear about. If it's not the blood pressure, it's the Pleth. If it's a low Pleth, what's the waveform? We talked about potassium. What about the calcium? How do you correct that? It's a low sodium. What's the glucose? The hemoglobin. Was it diluted? Or maybe it's the consult that you get. Is it real? That's the first thought that goes through the receiving consulting physician's mind. But then there's another step. What is really the problem? Maybe it's clarifying the existing problem. Is it epigastric pain, or is it substernal pain? They're not that far away from each other. And yet, one of those triggers an immediate association in your head. One of those might trigger associations that say, perhaps it's the GI tract. While the other one, after having done millions of year-old questions or chest questions, might say, it's cardiac if it's substernal. Or maybe it's recognizing that a problem even is a problem and labeling, for example, our non-pathophysiologic problems. Because if we don't treat it as a problem, it's tough to solve. Perhaps it's the patient's not taking their medications. That has its own differential. Is it access? Is it cost? Is it education? We don't treat it as a problem, it's tough to have an approach for it. Or perhaps, in the words of Dr. Willie Ross, I remember 8 years ago as he gave us our medical student orientation, said, patients are rational. You might not agree with the reasons, or you might not know their reasons, but they're responding to at least some sort of internal rationality. And that actually is not just limited to patients, that's to us too. O is for onset. If I tell you, no, I don't even give you the chief complaint. It's acute progressive. Doesn't matter what it is. You know you got to deal with it. If I tell you it's acute and improving, you might actually already have a sense for what the management is, regardless of what it is. Perhaps it's self-limited. Or it's chronic improving. It's possible, and probably probable, that you're going to keep going with the management course. And chronic stable, probably continuing with the management course. And so we see that if we're armed with just the onset and the tempo, that we already have a sense of what our management is, as well as the severity of the condition. And in fact, this actually sets us up for our differential as well, because this is always a question that we're going to need to figure out. And so it's worth spending a little time here when we're teaching our trainees about how to do that. Here are three questions that three approaches that I might use. Is it hours, days, weeks, months, or years? This can help us get, is it acute, subacute, chronic? What about Thanksgiving, or whichever holiday? Did you have it then? Or because we recognize in teaching our learners that this is so essential to how we set up the problem, that they spend the extra time to get the collateral, to know that we really need to know this information above all those other things. B is for baseline. Imagine you're a learner, and you show up and see to an ACT or a rapid response, and you see that the patient's on 6 liters of oxygen. It's pretty normal to be very overwhelmed by that. Patient's sick. Until you ask the nurse what their baseline is. They've been on 6 liters since admission. What changed? The problem is the gap between where they are now and where you're trying to go. As we can see on our graph here, we have our baseline. They have an acute illness. And we start treatment. Where are we trying to go? Has this happened before? They tell you this is this feels like the last time I had a COPD exacerbation, or this feels like my last heart attack, that massively shifts your pretest probability. How different from baseline and what's normal for you? If they're a marathon runner, and now they can only walk 5 steps, that's very different than I can only walk 5 steps normally, and that's how I am now. And then finally, and this is important, is that this scales with the stage of learner. The questions that we might ask as a medical student and might be a little bit more nuanced as we become an attending in order to adjust the pretest probability and shift what we think is going on. If we're dealing with dyspnea, then perhaps we ask better questions about cardiac and pulmonary history or modifying factors. So where did we land? We have 3 questions: real, onset, and baseline, with some key advantages. They're teachable from day 1. You don't need to know any medical knowledge to know whether something, to know the time course. You don't have to have any medical knowledge to really even ask, what is the actual problem? And you realize that's just generalizable to any problem. It's applicable to any concern. It triages. And then, importantly, it sets up the problem to be solved with high fidelity. We have a 50-year-old female with acute progressive dyspnea. You can make a pretty good differential just on that. We have a 65-year-old male with chronic, stable, intermittent abdominal pain. You don't know exactly what it is, but you have a pretty good sense of the ballpark of what it is. And finally, this is setting up the problem for high fidelity. Because at this point, we are armed with the information to realize what problem or to really think about what problem are we actually trying to solve. And this is a pretty common thing I see in learners, where if you ask the medical students, they get a message about low blood pressure, or you ask them, what's your approach to low blood pressure? And they freeze. Say, I don't know. But then if you ask them in just a ever so slightly different way, what about your approach to hypertension? Or maybe, even more simply, what's your approach to shock? And then they light up, and they give you, here's all the causes of shock, and here's what I do. And realize it's choosing the right map for the right territory. And that's a very important point so that we don't go down any false paths. Where do we go from here? This is the cart. We localize. We have more things to ask, but we're doing it with intention. C is for characterize. You may have learned a mnemonic back in medical school, OPQRST, Socrates, old carts. And these are helpful mnemonics. But you may have realized, wait, I don't use that for every concern that I come across. And that's in part because they're really developed for pain. And you can use them. All models are useful. All models are wrong, but some are useful. You can use them, but they just don't quite fit for some of the concerns that we come across. Or perhaps you've developed your approach for dyspnea. And importantly, this is different for every single physician. Perhaps based off your experience, or the literature that you've read, you favor baseline, pulmonary, cardiac, other, and hematology. And this will adjust, and as we think through the seasoned clinicians that we all admire for their very specific questions and very useful questions, we can think of this as a localization process. So here, perhaps this is your baseline distribution, knowing just it's acute dyspnea, where we're localizing this. And then we obtain a little bit more information that says, characterizing the dyspnea, that it's positional. Positional, perhaps that suggests that there may be some fluid, perhaps something else, perhaps it's diaphragmatic weakness, perhaps there's an aspiration component. And now our localization has shifted. We've got perhaps a little bit more cardiac, perhaps a little bit more other etiologies. And you can ask more questions to characterize that, to go further. A is for associated symptoms. And this is the same associated symptoms in old carts and in Socrates. But importantly, we're coming back to the order of questions. It's not just a checklist to pull off and say, I've asked all the questions of evaluating dyspnea. We're using this in a very clinically reasoned fashion to localize what the syndrome we are actually trying to solve. Are we solving dyspnea? Are we solving acute dyspnea with a positional component? Are we solving dyspnea with inflammation, which perhaps might localize a little bit more to the pulmonary system? Of course, there are some cardiac etiologies that can have dyspnea and inflammation. But this is a probabilistic process. And so we're hopefully becoming a little less wrong. And finally, perhaps we can categorize this differently. Perhaps it's an acute dyspnea with a negative exam. And this, in turn, would shift how we're thinking about this in our minds. R is for red flags. Because the goal for this was to be comprehensive, it's important that when we're teaching our learners that there are diagnoses we can't miss. And perhaps you might have heard a heuristic that was, tell me your differential diagnosis. Tell me the one that you can't miss, the most common, and something that's interesting. It's useful. All models are wrong. Some are useful. But it's not particularly comprehensive. So here's the actual formula, right, of the impact of our diagnosis times the probability of our diagnosis. And so when we're asking for a differential, what are we really asking for? We're really asking for a prioritized differential diagnosis. And really, that's the product of the impact times the probability and ranking that. And at a certain point, it reaches a threshold, and that's what we hear about on rounds. So perhaps it's our acute dyspnea. We've got our pneumonia, our CHF, exacerbation, our PE, and some things didn't quite make the cut given the particular characterization. But what's the gap between, or classic gap that we think of for the advanced medical student or the later learner is, so what's your plan? And there's a management differential. And so that's taking what our differential is, modulating it by the risk of intervention. Suppose we have acute dyspnea, but the intervention imposes costs to further evaluate it. And so we decide we're going to hold off. And so something got pushed below the threshold. Perhaps they have an IV contrast allergy. So we're going to evaluate the other diagnoses first. Or the risk might be just a little bit too much, it doesn't quite reach. T is for thoughts. And this is because you might have a wonderful assessment. But at the end of the day, it really matters what the gap between your understanding is and their understanding. If they don't agree with you, or if they don't understand you, or you don't understand them, then what are we really doing? It's just an academic exercise. So in my teaching practice, the way this looks is that I start off, I try to go for the signal over the noise. And what that looks like for me is I want to get to the assessment and plan. I hear either better, the same, or worse. And that already tells me, are we headed in the right direction? After day one, after they've proven that they can go through, tell me comprehensively what's going on, we skip the objective. And then I have them tell me what their big picture is. What's the critical path? The one-liner. But it's a thoughtful one-liner. It's not the details of the antibiotics. It's they were in septic shock, they made it to the MICU, they're coming out, they're improving on day whatever. Or it's heart failure exacerbation, admitted on what day? Because heart failure exacerbation on day 1 is very different from day 10. One of those orients very differently. And then I ask for the hospital indication and the rate-limiting steps for disposition. So they clearly demonstrate that they know the big picture. They're in multi-organ failure, and we're talking about lower impact problems, or they're missing the big picture, then what are we doing? And finally, we go through the structured assessment plan, and this is where I spend the vast majority of my time. In practice, we'll go through this for just a moment. It's a really, this mnemonic and framework has been very useful for teaching learners. But as educators, as everybody in this room is, we're really looking for a way to give better feedback and assess what's really going on. And so perhaps they obtained their HPI using RobCard. It's a long one. And you're hearing them tell it, and you have thoughts. And then you ask them for their big picture. And they summarize it like this. It's a 50-year-old female with acute progressive dyspnea, faint crackles, and associated fever, trace bilateral lower extremity edema. You may already have the answer in your head. You have a gut association. It says, it's most likely this. But the learner might not have that, because they don't necessarily have the experience that you do. And so it's at this point that we might apply a schema or an approach. Perhaps it's your approach to dyspnea, which is different for everybody. Or certainly it's weighted differently for everybody. And that leads us to a prioritized differential diagnosis. As we mentioned before, some things met our cutoff and other things didn't. And the next step here is now looking, what are we actually talking about? What's the plan? And the big learning point that I've seen, for myself at least, is clearly linking the differential to the action. Sometimes in our zest for wanting to get to the plan, we realize that although they might have the right plan, they might not have gotten it the same way that you did. Not to say that they need to get there the same way, but just because they have the right plan doesn't necessarily mean that they approached it the right way, or maybe they weren't even the ones to come up with the plan. So how do you know whether they really understood how to get there? And that's the generalizable point for how you can learn for the next patient. And if you notice, this maps actually quite neatly into our learning points, or how we assess our learners. For example, was there a problem with getting the actual data? Does this corroborate with or jive with what you were able to come up with? Was there a problem with synthesis and the gap between their HPI and their problem representation? Or perhaps it was a problem with getting, if you gave them this, they couldn't get to their prioritized differential diagnosis. They were missing an approach. And so sometimes when they're giving me the HPI, depending on what I'm trying to figure out or assess from them, I will summarize back what I hear from them and see whether that helps them with coming up with a differential diagnosis. Or is the problem that they couldn't put it together to set up the problem to be solved? And I'll ask this, what is the actual problem you are trying to solve? And finally, is it a fund of knowledge gap? Given my concern for pneumonia, what's your plan for the antibiotics? Well, I didn't even know that they should be on antibiotics. That would be a knowledge gap. If it's a heart failure exacerbation, what's your next steps? Tell me about GDMT. And so this is what really builds our hypothesis-driven, actually, evaluation for the learners, but also an learner's approach to problems. Where at each step, we can actually evaluate and coach on how to get to the next level. So in closing, I want to close with a quote from Hippocrates as we all go on this journey together. That life is short, art is long, opportunity fleeting, experience treacherous, and judgment difficult. I was here 8 years ago, and it's been a wonderful ride. I want to say a thank you to to some of my advocates along the way, some of them who are listed here, to get to this point, and thank you very much for your time.
Great job.
Thanks.
Transition. We will hold questions until after Dr. Wallenkampf's presentation. So, and we'll have questions for both speakers at that time. Next, we have Dr. Karl Wallenkampf. Dr. Wallenkampf obtained a Bachelor of Science in Biology and a Bachelor of Arts in Humanities with a concentration in English from Walla Walla University. Afterwards, he obtained his MD and Master of Arts in Medical Ethics from Loma Linda University, followed by internal medicine residency and chief residency here at WashU. He has made a point about bringing humanism into medicine. Of everyone I've ever worked with in my career, albeit short, no one has been as focused on the humanity of every individual as him, treating every person he interacted with as a human that they are. As a med student, he led a group working on professional identity formation and was the first fourth-year med student to join community groups as a mentor. He has served on the Ethics Council Committee since residency and even spoke here at Grand Rounds 2 years ago about the history of medical ethics. In addition to this, he's known for his immaculate prose as exemplified by his eloquent soliloquies in the daily emails. And yes, I did try to use more complex words in that statement to match his mellifluous statements. Where was I? Sorry. He has a remarkable sense of humor, a true sense of authenticity that emanates in all that he does, and of course, excellent clinical acumen to complement these traits. In line with this, he won Teaching Resident of the Year as a senior resident last year. Unfortunately, he will be moving to greener pastures or significantly taller mountains this next month when he joins the cardiology fellowship program at the University of Utah. Today, he will be talking about how the Pleth can help us understand our patients as humans. So please help me welcome Dr. Wallenkampf to Grand Rounds.
Thank you so much, Edward. And thanks to all of you. I just want to really reiterate exactly what Francis was saying in my deep gratitude. Being able to train here and be a chief resident here is the opportunity of my lifetime. So I'm profoundly grateful to all of you for the presence that you've had with me, the influence you've had on my life, the time we've spent together. It's made me much more of who I am, and I hope what I can give back to my patients. Sometimes I think that one of the beauties of medical education is that you might be able to teach someone something, and they embody that, and they practice it and teach someone else. And even if I am eventually forgotten in that practice, something that I taught is being carried on forward. And all of you will have influenced me in that way. So I'm one of the chief residents that you just heard. I've been hearing a lot from residents, "Are you okay, Karl? Are you okay?" And I think they ask this because of my daily emails, which have recently mentioned things like meringue and how I used to eat meringue in the mornings. I've had a lot of adages. And I think that all of this may be because of the delirium that is existing in my mind as I head close to the end of chief year. But maybe it's the positivity of my emails, which is fairly undying. And to that I say, chiefs are propagandists. So appreciate what you can out of that. I won't answer if I'm okay today. But I do intend today to discuss an answer to a different question, which is, what have I been thinking about? So thank you for being here. The following, I think, overlaps nicely with Francis's talk, because I want to discuss elements of knowing and caring in medicine and the different layers of which they appear. With that, we're going to cover several bases. So first, I want to discuss plethysmography. That will be the foil for the talk. It will be the undergirding, and we'll illuminate 3 different cases that I think demonstrate how we can know and care in medicine. I'm identifying what I'd like to call the reliable pleth, the confounding pleth, and the whole pleth, and then we'll discuss the surge from here. In order for you to get CME, I was required to place learning objectives here, but I want to note that these learning objectives, I submitted them before my ideas fully crystallized or hallucinated in my mind, and so I will cover these topics, but hopefully things have evolved from there. So we'll discuss the moral facets of our patients, and we will work to define principles of accompaniment in our clinical work. Plethysmography. Plethysmography is the study of volumes and its measure, and informs our use of pulse oximetry, which is our 5th vital sign. Plethysmography depends on the chemical nature of hemoglobin and the flow of the cardiac cycle. As blood moves through the capillaries, they can be exposed to an LED with separate wavelengths of light. Red light is best absorbed by deoxyhemoglobin. Meanwhile, near-infrared light is best absorbed by oxyhemoglobin. This is a wonderful reality and allows us to make an external, non-invasive judgment about the oxygenation of our patients. I want to point out this image here, and what you can see here in this image just illuminates a little bit of what I was saying. So up here in figure A, you can see some of the assumptions that we make whenever we take pulse oximetry and plethysmography. You can see this cardiac cycle influencing this pulsatile, or you could say alternating current of the arterial blood flow and its absorption. Meanwhile, every time we do pulse oximetry, we are assuming that there are things that remain constant. That is the absorption of the venous and capillary blood and stationary tissues that surround the arterial blood. Because obviously these wavelengths are going through, for example, a whole finger, a whole ear, or when they put it on a forehead, I guess the whole brain. Here, you can see the change in red light absorption, a little diagram of what arteries and veins look like as they appear in humans. And then this is what I want to show you here in C is just an element of, on the diagram of, on the left-hand side, demonstrating that deoxyhemoglobin better absorbs red light and oxyhemoglobin better absorbs infrared light. You can notice that because if you prick your skin, you will see this bright red reflected at your face as you take that in. The blood is, your oxygenated blood is absorbing infrared, reflecting that red. You might remember critically ill ICU patients as their blood was being drawn in that initial moment in the deep maroon, that ominous maroon. So plethysmography. It's the study of measure and volumes. We've discussed a little bit of its facets. And importantly, plethysmography involves assumptions and interference. We're making some assumptions of baseline absorption. And meanwhile, we have interference from things like IV dyes, hemoglobinemias, light pollution, nail polish, and yes, skin tone. And my novitiate days of medical training thus far have been punctuated by the question so many times, how does the pleth look? Very much in what Francis was saying, is this real? The underpinning of this question, how does the pleth look, and how we'll move forward here today, are deeper questions. What are the ways we can know in medicine, and how do I care in the specific clinical encounter? We're going to cover these three things, as mentioned, the reliable pleth, the confounding pleth, and the whole pleth. This last image was created with artificial intelligence. I've lost years of my life to trying to get this image to work, and it still didn't work out completely. And I won't get those moments back, but there it is. So we'll begin with the late night call. So I heard the chilling sound of Vocera that maybe some of you have heard, the da-da-da, can you take a call from Med1 night resident? I said yes. The resident shared with me a story of desaturation, a veteran with this usual cornucopia of complications and comorbidities, including moderate but very precarious COPD. That evening, something had set off a cascade that had resulted on 10 liters of nasal cannula and desaturations, and I was told, I think he might need a higher level of care. I went to go see the patient. I found him gasping, his lungs wheezy and tight. I spoke with him and I examined him. The pleth was continuous, cyan blue, waving with each systole and diastole, thankfully 97%, though supported by a fair amount of oxygen. I looked at his gas, which we drew. It was acidic and hypercapnic. We started BiPAP. It was that beautiful. It was perfect. His wishes were clear. They were made so in the notes throughout his chart, in his nods, and in my discussion with his wife. He wanted to follow medical indications. He wanted to pursue life as long as it was possible. Yes, he was very anxious, and as I learned, he had PTSD with severe nightmares every night. Perhaps they had set them off. We started BiPAP and steroids, and he improved. I was thus faced with knowing in the clinical encounter. Our data and medical indications were clear and reliable, as were his preferences and the impact of quality of life on our interventions. In this encounter, we had high objective fidelity, high subjective clarity. That is, we had a reliable pleth, reliable waves flowing by, the background undisturbed by undue features. This moment identifies the first, and I would say currently supreme means of knowing in medicine. That is a powerful, cognitivist, and reductivist manner that has the power to generate our vast armamentarium of diagnostics and therapeutics, which has obvious effectiveness. We were able to help this man by viewing things in terms of concrete problems that are isolatable. They are basic. They are atomistic. We try to limit confounding factors. We prioritize a kind of Cartesian cogito ergo sum. I think, therefore I am, and that mind-body dualism in that process. This is valuable. It's critically valuable in our way of knowing along our search for the good Pleth. It is generative. It produces the very evidence we use to treat this patient with a high success rate. It empowers technical solutions to disease, and our patients seek it. They seek our best evidence. Healthcare is incredibly expensive, and using this mindset can create powerful solutions. Our healthcare costs are somewhere in the range of 17% of our GDP. For reference, though it's not an apples-to-apple comparison, our military budget is 3.4% of GDP. These beset us with commodification of care, commodification of labor, and commodification of the patient-physician relationship as we try to reduce costs. To assist us, we've faced the inevitable rise likely of artificial intelligence, which has its own forms of atomism, of cognition and generation, generative AI, which in the near future are likely to become superhuman in anything that can be done on a computer. And yes, I'm thinking about the electronic health record and the 6 or so hours we spend on it for every 8 hours with patients. I spent much of my time in that room documenting. Here, knowing and caring in medicine, we're able to reach our synchrony. We were able to base our care on strong cognitive knowledge. They were sufficiently stable to allow us to apply rigorous external data. And I think it's likely that we'll see further adoption of artificial intelligence in moments like these. But this way of knowing influenced how I cared for him. I was able to care for him, act on his behalf, discuss with his wife, attempt to call him as he initiated over 80 calls to his daughter and wife because they weren't picking up. He was clearly anxious, and I worked my best to relieve his anxiety. But I will say I limited my time. I thought about this in terms of the disease process, the mechanisms I had at my disposal to solve this disease process, the differential that I was building with the resident about how we could address the concerns, and I will admit I saw it in some ways as an impediment to my evening and the daily email I needed to write. I identified his moral status largely in terms of his biology and in terms of his cognition, and to some extent in terms of his relationship with his wife. While the means of knowing and caring in this case were powerful, they can also spur distrust. We have seen, after the COVID-19 crisis, a decrease in trust of leaders in medicine. I would like to think many of us in this room, all of you are or will be soon leaders in medicine. What may be clear to the assimilating minds of physicians may not be clear to our patients. Just like Francis was saying, that final term of thoughts. There may be a delta between our understanding of the data and their understanding of their lived experience. When we hear calls to say, follow the science, this delta may cause issues in patients' adherence and trust in us. These are wonderful ways of knowing, reliable, generative, but they're not the only ways to know. They were sufficient for this case, but they're incomplete. As Eric Cassell notes, it is the burden of doctors to have great responsibility in a sea of doubt and uncertainty. The intrinsic promise of technology, that it will relieve uncertainty and lighten doubt, is virtually irresistible given the special circumstances of medical practice and the stakes therein. So we reviewed the reliable Pleth. Knowing in this term is often more cognitive. Our caring may be in some ways limited, and the moral status of patients which we observe and work upon is often biological, cognitive, and yes, in some ways relational. Let's transition to the confounding Pleth. I was late in intern year when we received the blaring sounds of our ACT pagers, the overhead call for an ACT response to somewhere on 5400. We joined the school of onlookers and joined the hard workers, gathered along with the onlookers, and found a man who was working hard to breathe. His face was pale blue. His skin was waxy, his belly was distended. We looked at the Pleth. It was unsure, notchy, faltering. The number in the 60s was terrifying to us, but we couldn't be sure if it was real or not. But we could see and hear many other things. We could see the look of his cyanosis, the sounds of his tachycardia, his decreasing blood pressure making it impossible to feel a pulse at his wrist. Also, he could feel the coolness of his skin. We listened to a primary team member discuss the history, including cryptogenic cirrhosis, a transplant which had been complicated multiple times with ICU admissions and intubations. He became more critical, and anesthesia was called to intubate. I left the room to take over a discussion with the family, his wife standing outside. And suddenly it clicked. I had taken care of him months before. He had been on my service and was my patient when he was admitted for an inpatient colonoscopy in his pre-transplant evaluation. I had spent hours at his bedside, coaxing him through gallons of Go Lightly, alternating with Sierra Mist, which is now Starry, and talking with him and his wife about what they enjoyed. It turns out that they lived in a small town, not a long ways from here, actually. They were active members of their church. They were also active members of a building committee because the church was building a new wing, and he wanted to be there when it went up. I arrived there with a wife who was authoritative, humorous, and a teacher, and now she was awestruck, devastated, standing outside the room. A chaplain was by her side, already providing comfort, and I drew near as we began to discuss the case. I heard a call from the room saying, "I don't have a pulse," and the chaplain and I drew even closer and started handing her tissue. I slowly asked questions. Did he still want to be there when the new wing was erected? And she responded, he hadn't been there and it was up now. Has he changed his views on code status given his recent ICU stays? He hadn't, but he appears even more tired. Another team member came out. Would you like us to continue? She sobbed as she assented and then looked up at us, the chaplain, the physician, and said, "If I let him die, will God forgive me?" Along the search for the good Pleth, we find confounding Pleths. These are the ones that abut our categories of knowing, slip out the seams of our structures, demand a higher level of awareness, observation, a more holistic view of knowledge, and expand and demand our capacities for care. They may have dynamic, unremitting, and seemingly irreconcilable medical information and presentations that obscure the medical indications. They carry diverse, profound weight in the term of moral commitments of patients and their families, textured emotions, psychological hazards. Cases may be beset by overwhelming contextual legal or other social features. Knowing in these cases is more than the cognitive reductionist approach, though it benefits from these skills. We were using plethysmography. We were intubating with an ET tube. We were there giving medicines that are all based on a cognitive form of knowing, but that is only part of the picture at hand. As Patricia Benner and Judith Rubel, two nurses and philosophers in the Ethics of Nursing, note, the dominant view of knowledge in the Western tradition emphasizes abstract, general, theoretical knowledge while overlooking and devaluing local, specific, practical knowledge and expert clinical judgments about particular situations. Michael Balboni and Tracy Balboni, in their, in my opinion, masterwork, Hostility to Hospitality, note, doctors trained in the last two generations, or this is Eric Cassell, we'll talk about Balboni's in just a moment. Doctors trained in the last two generations have difficulty dissociating medicine and science, but their historical ideals are distinctly different. Science is based on a belief that it and its methods are value-free. Anything that happens in nature is neither good nor bad, it simply is. On the other hand, medicine has a tradition in which a hierarchy of values, the patient comes first, doctors must above all do no harm, the good of the patient is intended, is firmly established. Caring in these moments demand the heights of clinical acumen, exactly what Francis is discussing. Meanwhile, humility before the patient's shared engagement with the event of illness, that moment of thoughts. As the Balbonis note, the patient's illness is located within the body, but cannot be limited to the body. Serious illness raises basic questions about identity, the meaning of life, and what happens after death. It is a disruption of relationships between loved ones, raising existential questions around the permanence of their disruption. This is a picture I took at the Brandenburg concentration camp. This place right here is where volunteer German physicians determined the means of the final solution. Physicians and ethicists Larry Churchill, Joseph Fanning, and David Schenck note in their book, What Patients Teach, the everyday ethics of healthcare. They propose a view of relationship and caring that they term doubled agency. The body presents itself ill or healthy, and in so doing is an appeal. The healing practitioner is one who accepts the authority of that appeal and responds to it, and in so doing forms a relationship of interdependent vulnerability and responsiveness with the patient, capacity and risk that are required in the tethers of trust. In moments like these, the ability to bear this complex balance is difficult. These moments are at the crux of the physician's role, inviting the responsiveness of the caregiver in more ways than one. We become embedded situationally. We become interdependent, and we have doubled agency. The patient's agency is coupled with our own. So we reviewed first the reliable pleth and its forms of knowing, caring, and moral status, and we just went through the confounding pleth and its embodied knowledge, its embedded caring that is doubled and tethered with a patient in their vulnerability and our responsiveness. And the moral status of the patient becomes even more dynamic. We see them as moral agents that are inhabiting space alongside us. We are recognizing their sentience, the qualia that they experience of the world around them that perhaps may not be shared by a purely cognitive or artificially intelligent role, and the relationships that they hold dear. Let's finally turn to the whole pleth and then close. The final pleth is found in many moments. I'm sure each of you has experienced many of these. I did specifically one moment in December in my third year of residency last year. I took care of a woman with lung cancer and pneumonia who was cachectic. She was admitted for hypoxia due to her pneumonia. We had her on antibiotics. But her guttural breathing was a harbinger of doom. And over days we discussed with her, in as much as we could understand through the face mask and her family, what her wishes were, and it became apparent with clarity of indication, clarity of her preferences, and the clarity of her quality of life that these were her last days. Knowing in this moment, what could we do? What then? What is knowable in moments like these? It ceases to be only a cognitive issue, though it was that in many ways. We had reviewed her CT evidence. We had discussed with hematologists and oncologists about her care. We were giving her antibiotics, which are founded on these reductivist, cognitivist views of how we see the world that have been generative and given us tools. However, it may be tempting to leave because these tools were no longer at work, or these tools were no longer possibly effective. All our reams of evidence, our scans, our pleths, our basic science, it all seemed like we had lost in this moment. But as the ethicist Paul Ramsey describes in an essay titled "On Only Caring for the Dying," the patient has entered a covenant with the physician for their complete care, not for continuing useless efforts to cure. This grounds the patient in preferences and the quality of life. We seek the meaning in the unknowable and shared anticipation. As he notes, even when no treatment is available and no cure is possible, understanding the meaning of the illness for that person is a form of healing. And in that, such understanding can overcome the sense of alienation, loss of self-understanding, and loss of social integration that accompany illness. This grounds the patient and allows us and the patient to find meaning while facing the unknowable with shared anticipation of a fate that we all share. As he notes further, the sting of dying is solitude. What doctors should do in the presence of the process of dying is only a special case of what should be done to make a human presence felt to the dying. Desertion is more choking than death and more feared. The chief problem of the dying is how to not die alone. To care, if only to care for the dying, is therefore a medical moral imperative. It is a requirement of us all in exhibiting faithfulness to all who bear a human countenance. In these moments, we seek meaning in the unknowable and shared anticipation, and caring takes on new meaning as well. It avoids retreat. It chooses to accompany and resist solitude while we accompany the patient. As we go on, it shares fate for a while and embodies recognition of a shared humanity. Paul Farmer, a recently passed away infectious disease physician, who has done a lot of work overseas, describes accompaniment in a beautiful way. The companion, the accompagnateur says, "I'll go with you and support you on your journey wherever it leads. I'll share your fate for a while." Accompaniment understands the fundamental shared continuity of the patient and the physician that we share in these moments. As Ramsey says, acts of caring for the dying are deeds done bodily for them, which serve solely to manifest that they are not lost from human attention, that they are not alone, that mankind generally and their loved ones take note of their dying and mean to accompany with them in accepting this unique instance of the acceptable death of all flesh. So in those moments, that one morning, I was able to sit with her at the bedside, hold her hand, read from books aloud as she nodded off and dozed, hypoxic. Her monitor turned off because we knew everything we needed to in that moment, and caring was demonstrated by accompaniment. So the search for a good pleth, how we know within the clinical counter predisposes us. We may elevate our knowledge over being, experience, and value. The cognition, which can be our greatest power, can also pull us from embeddedness and interconnection. Even my own favorite field of medical ethics can be a form or tyranny, can be a form of tyranny in the clinical encounter if it does not become incarnated in the relationship between the patient and the physician. It humbles and embeds our ethics. A long quote here that I'll move through briefly, but I want to point out that Churchill, Fanning, and Schenck note that our Enlightenment views can be at risk with a solely unencumbered actor. Instead, the moral dimension of healing interactions and patient-centered care rests in the patient's moral authority, not just to refuse care or the right to be treated with respect, but their moral authority is having their framework of experience taken seriously as a basic normative structure for shaping the moral imagination of those who are committed to helping them heal. Our search for a good pleth tethers us in community with our patients. Embodied ways of knowing help us to recognize the moral status of our patients. Not merely biological, though it is that, not merely moral, though it is that as well, cognitive, sentient, and relational. We become trained and attuned to accompaniment. We learn to advocate for our patient, resist alongside them, and abide with them. I cannot define the good pleth for you, though I can give the description I just gave. My hope is that this search for the good pleth does encourage you to increase and enlarge and become full in your understanding of the practice of medicine. As I am early, many of you are beyond me and have mentored me in this way. I hope that whatever the advancement of our technology and science, our moral imagination grows as well. It also increases, enlarges, and becomes full. I'll leave you with these comments from Patricia Benner and Judith Rubel, who note, involvement and caring may lead one to experience loss and pain, but they also make joy and fulfillment possible. Thank you.
Thank you both. Those were terrific talks. Maybe we can turn up the lights and have a few minutes for questions. So I'll start. Oh, is there somebody? Oh, Steve, no, go ahead, Steve.
So I have questions for both of you guys. Maybe I'll start with Francis. Francis, when you are approaching a clinical problem, your algorithm is awesome, but it often seeks to find unifying diagnoses, and sometimes in real life, it is true unrelated.
Sure.
So how does your approach reconcile that? Because sometimes it doesn't all fit into one picture, and sometimes you are looking at two separate processes. How do you swing back and reevaluate?
Sure. So to recap, the approach was real, onset, baseline, characterized, but actually I toyed with whether it should be choosing your schema, and then associated symptoms, real, and thoughts. And so for reconciling this, for example, if they have an abdominal process and a thoracic process, could be a generative process leading to the abdomen that then goes to the thorax. It could be an abdominal process going to the thorax, it could be a thoracic process going to the abdomen, or it could be an underlying systemic process that goes to both. And so it really comes down to, as you're trying to localize what's going on, suppose it's, and I just didn't mention it initially in the talk, but if you have, let's say it's acute dyspnea plus inflammation plus a cough plus a headache, right? You've got 4 symptoms there. How do you actually put this together? Maybe there's nausea, but this is where the skill of the clinician does come in, but it scales in that sense. And so you can really think, am I approaching dyspnea with a cough, or am I solving cough with an associated dyspnea? And so that is where we can actually coach as educators to kind of make that distinction between, is it 2 separate individual processes or one generative process providing both?
And then, Karl, I have an awful question for you, and it is a difficult question, and I would love to just hear your thoughts on this. That not so long ago, at the height of the COVID pandemic, we had patients who were in the hospital in critical situations, near death, and because of fear of contagion, there was a lot of isolation. There was a lot of physicians not being with their families, not being with their patients, not having a good death and being alone. And that was done to try to balance these different factors. Your thoughts on if we could do this again, would you have done things differently, or was this the best for the overall good? Thoughts on that?
Yeah, thank you for the soft lob there, Dr. Chang. So briefly, I see the problem in terms of one that is grounded in bedside ethics as well as public health ethics. I specifically did a degree in medical ethics that's very grounded at the bedside. I did not get a master's in public health. But I want to point out that I think that the decisions we made in the COVID pandemic, we meaning the practice of medicine generally, the propagation of what we were finding out scientifically, we're finding more and more that the messaging that we used in those moments took into account, I think, a lot of scientific realities, 6 feet of difference, 6 feet of distance. Now that itself is in some ways arbitrary. We'll try and limit the spread of contagion. I abide in that, and I think that that's an important valuation, but I think there could be a change in messaging and a change in understanding that what ethics are we upholding in that moment, what is the value that we want to uphold, and to be more open and apparent with that with our general population. In many ways, I wish that we had been able to open a few more things, take a higher risk, perhaps ask for volunteers to say, are there volunteers who are willing to continue abiding at the bedside while families come in and spend time with their loved ones? I think there may be a way to reshape it.
I just want to say thank you so much for both of your really great talks. My question is for Karl, and I'm trying to figure out how to phrase it in the best way. But I think with your talk and kind of reconciling the knowing, the caring, and the cognition, do you have tips about how to incorporate it in your daily practice? So I'm thinking of a scenario like you're on call, you're so busy managing all these different things, and then you do have a situation where there's an act, someone passes away, and you have this very emotional taxing and emotional investment in that moment, and then you immediately shift gears, you don't have time to process it, you're moving on and kind of focusing on the rest of your day. And I feel like we encounter those scenarios almost every day out of perm, almost every day in ICU. So I guess my question is how can we be mindful and incorporate it into a daily practice while also being able to complete all the demands of being a physician?
Yeah, I think that this is really key, and one of the deep challenges of our practice. So a couple of the things, I think Jen Larson said that I should include a summary slide with practical tips, so thank you for that point. So a couple of things that I think about are, in a course of an entire day, where can I do this a couple of times? I think as we are in a sense of becoming as ourselves and people and clinicians, the more times we decide to do something or not do something, the harder or easier it becomes. So there are busy days when I don't sit at the bedside. I was able to sit at the bedside with that third patient because Nina Mannion and Reed were doing an incredible job managing all the other patients, and I was 15 feet away from our call room. So, but choosing to decide, is there a single patient where I can do this today? Is there a moment where I can take an extra 70 seconds to ask someone, hey, what are you famous for? What brings you meaning outside of work? I want to keep the thread alive. It may not be present in every interaction, and it absolutely is not in every one of mine, but I want to uphold that flame. So that would be one. There are a lot of practical tips on how to engage with a patient to get a fuller explanation. I mentioned one a little bit in my grand rounds last year on the clear whole person care model, so approaching patients to connect with them, listen with them, explore their ideas with open-ended questions, acknowledge what they're saying and respond. So I could talk about some other practical tips as well, but what I want to emphasize is this, in some ways, will be impossible with every patient, but to center ourselves in an embodied care for them. Some moments you can't, like in a code situation, I have to separate my emotions to some extent to be able to get through the trauma of that moment, but can I hold that space later? Can I tell my team, we're busy today, but tomorrow morning at 11, we're gonna have a talk about how the code went.
Thank you both.
Nicely done, Karl.
Thank you. Hello?